It is 2:47 in the morning. The house is dark and completely quiet. You are finally sleeping, real sleep, the deep kind, and then the pressure starts. Dull at first, then insistent. You hold on for as long as you can, but the signal keeps building until it cannot be ignored. You push back the covers. Your feet hit the cold floor. You shuffle down the hall in the dark, eyes half closed, one hand on the wall. You use the bathroom. You come back. You lie down. And now your mind is running. Work, money, tomorrow's schedule, and sleep is gone. You stare at the ceiling for an hour. You finally drift off. And at 4:15, it happens again. In the morning, you pour coffee into yourself before you can form a complete sentence. By noon, you are exhausted. By evening, you are dreading going to bed. You have told yourself this is just what happens after 60, that this is age, that everyone deals with it, that you just have to manage. I need to tell you directly, that is wrong. And that belief is quietly costing you something you cannot get back. Here is what nobody has explained to you yet. In the overwhelming majority of people who wake up repeatedly at night to urinate, the bladder is completely healthy. It is not the source of the problem, it is just the messenger. And every pill, every supplement, every herbal tea you have been taking, aimed at your bladder or your prostate, has been sent to the wrong address. The organ that is actually disrupting your nights is one your urologist has never once mentioned to you in this context. Stay with me. My name is Dr. Chandler. I specialize in gerontology and age-related disease prevention. The intersection of how multiple body systems change after 60 and how those changes interact in ways that standard single specialty medicine consistently misses. Nocturia, the clinical term for repeated nighttime urination, is one of the most mismanaged conditions I see in older adults. Not because the science is unclear. The science is very clear. But because the cause lives in a system that most people, and many physicians, are not looking at. A landmark study published in the Journal of Urology followed over 40,000 adults and found that waking up 2 or more times per night to urinate was independently associated with a 26% increase in all-cause mortality risk in adults over 60, a risk magnitude comparable to uncontrolled hypertension. The same study found that over 60% of cases were attributable not to bladder pathology, but to nocturnal polyuria, a disruption in how the kidneys distribute their workload across the 24-hour cycle. I want you to stay through to the end of this video, because in the final section I am going to give you a 3-part evening protocol, 5 minutes total, that addresses the actual physiological cause of your nighttime urination. Not the symptom, the cause. And I am going to explain why it works, mechanism by mechanism, so you can verify every word with your own physician. But first, I need to give you the diagnostic framework, because the wrong diagnosis leads to the wrong treatment, and the wrong treatment, in this case, actively makes things worse. Here is what 2 or 3 nighttime awakenings are actually doing to your body, and why this is not a minor inconvenience. Deep sleep, what neurologists call slow-wave sleep, is not simply rest. It is a biological maintenance window. During this phase, your brain runs a dedicated waste clearance system called the glymphatic system. Cerebrospinal fluid pumps through your brain tissue, physically flushing out metabolic byproducts, including amyloid beta, the protein associated with Alzheimer's disease. This clearance only occurs during deep sleep. It cannot be compensated for during lighter sleep stages or during the day. Every time you wake up at night, you interrupt that process mid-cycle. And the evidence on what chronic sleep fragmentation does over time is no longer ambiguous. A 2021 meta-analysis in Sleep Medicine Reviews covering 127,000 participants confirmed that nocturia-related sleep fragmentation, 2 or more awakenings per night sustained over years, is independently associated with a 36% increased risk of type 2 diabetes, a 28% increased risk of cardiovascular events, and measurable acceleration of cognitive decline in adults over 65. The authors concluded that nocturia should be treated as a cardiovascular and neurological risk factor, not merely a urological complaint. If you continue treating this with bladder pills and fluid restriction and accept it as an inevitability of aging, that trajectory is what you are accepting, not inconvenience. Accelerated systemic decline. But here is what matters most. This trajectory is reversible. The physiology that is driving your nighttime urination is understandable, addressable, and in most people over 60, correctable without surgery, without a prescription, and without spending $1 beyond what you already spend at a grocery store. Let me show you exactly what is happening inside your body at night, and why the real culprit has been hiding in plain sight. Before anything else, you need to understand which type of nighttime urination you are dealing with. Because the mechanism is different for each type, the treatment is different for each type, and what helps one can actively worsen another. Type 1 is called global polyuria, producing too much urine across the entire 24 hours. The pattern: you urinate frequently both day and night. Each visit produces a large volume. Your urine is consistently pale, almost colorless, nearly odorless. If you measured everything you produced in a single day, it would exceed 3 liters. The likely causes are either excessive fluid intake, the always carry a water bottle habit taken too far, or undiagnosed diabetes, where elevated blood glucose pulls water into the urine osmotically. If this is your pattern, you need an endocrinologist and a fasting glucose plus HbA1c blood test. This is not a bladder issue. Type 2 is called nocturnal polyuria, and this is the type affecting 60 to 70% of adults over 60 who report nocturia. The pattern is distinctive. During the day, completely normal. You visit the bathroom every 4 to 5 hours. Nothing hurts, nothing burns. But the moment you lie down, the night becomes a series of full bladder awakenings, producing large volumes each time. In the morning, you look at what you produced overnight, and it makes no sense relative to what you drank the evening before. Your kidneys have inverted their schedule, running at low capacity during the day and flooding output at night. I will explain exactly why this happens in a moment. It is the most important mechanism in this video. Type 3 is a reservoir problem. Here the pattern is opposite. Urges are sudden, intense, and urgent. But when you reach the bathroom, almost nothing comes out. 30 minutes later, the cycle repeats. The issue here is the bladder itself. It has lost the capacity to stretch to its normal volume, or its nerve signaling has become hypersensitive, triggering an alarm at 60 milliliters of urine when the normal threshold should be 200 to 300. This occurs with benign prostatic enlargement in men, overactive bladder syndrome in women, or chronic low-grade bladder irritation from diet or infection. Lock in your type. The rest of this video is primarily about type 2, nocturnal polyuria, because it is the most common, the most misunderstood, and the one for which the real cause is almost never explained to patients. I want to tell you about Richard, 67 years old, retired high school principal from Phoenix, Arizona. A precise, organized man who kept a health log. When he came to see me, he brought it. A spiral notebook going back 4 years, logging every nighttime awakening. Year 1. 1 to 2 awakenings a night. He accepted it. Year 2. 2 to 3. He saw a urologist who found mild benign prostatic hyperplasia, a very common and usually minor enlargement of the prostate gland. He was given medication. The awakenings continued. Year 3, 3 to 4 times a night. He added a herbal prostate supplement he had seen advertised. He stopped drinking water after 5 p.m. He eliminated coffee entirely. He went to bed so thirsty some nights that he kept a single sip of water on his nightstand to wet his lips. And he still woke up at 2, at 3:30, and at 5 a.m., producing 300 to 400 milliliters each time. 4 years. 4 years of progressive sleep deprivation, increasing morning exhaustion, reduced concentration, 2 falls in the past 8 months that he dismissed as clumsiness. His wife had moved to the guest room because his constant movement through the night was disrupting her sleep too. When Richard sat in front of me, I looked at his urological workup. His prostate was mildly enlarged, but nowhere near sufficient to produce this clinical picture. His bladder ultrasound was clean. His PSA, the prostate cancer marker, was normal. From a purely urological standpoint, this man was near healthy, so I stopped asking him about urination, and I started asking him about something else entirely. Richard, at the end of the day, what do your feet and ankles look like? He paused. A little puffy, I guess. My socks leave marks. I asked him to pull up his trouser leg and roll down his sock. He did. I pressed my thumb firmly against his shin bone for 12 seconds and released it. A shallow pit remained in the skin, clearly visible, slow to fill back in. I told him, Richard, your prostate is fine. Your bladder is fine. I am referring you to a cardiologist and a sleep medicine specialist. He looked at me the way every patient looks when I say this, like I have completely lost the plot. My heart? I'm getting up to use the bathroom. I told him, give me 10 minutes and I will show you exactly why those two things are the same problem. Here is the physics. During your waking hours on 15 to 16 hours per day, like you are vertical. Gravity is pulling everything in your body downward. Blood, lymphatic fluid, the interstitial fluid that lives between your cells. All of it drifts toward your legs and feet. When we are young, this is managed efficiently. The venous valves, small one-way folds of tissue inside the veins, hold blood firmly and prevent it from pooling downward. The calf muscles, when we walk, contract rhythmically and act as a biological pump, pushing venous blood back upward toward the heart against gravity. But with age, particularly with a more sedentary lifestyle, two things happen. The venous valves lose competence, they become slightly leaky, and the calf muscle pump runs less frequently because we are sitting for longer stretches. The result, fluid seeps out of the blood vessels and into the soft connective tissue of the lower legs. Quietly, invisibly in many cases, no dramatic swelling, just a slight puffiness, a sock mark, a feeling of heaviness by late afternoon. In a sedentary adult over 60, this fluid accumulation can reach 1 to 1.5 liters over the course of a day, hidden in the tissue, not circulating, not being filtered by the kidneys, just waiting. Then you lie down for the night. The moment you become horizontal, gravity no longer holds that fluid in your legs. Over the next 30 to 60 minutes, it begins draining back into the venous system and flowing toward the center of the body. 1.5 liters of fluid suddenly returns to your circulation. Your blood volume rises sharply. Your heart detects this. Specifically, the right atrium, the upper right chamber, begins to stretch beyond its normal volume as the additional blood arrives. And here is the critical response. The atrium releases a hormone called atrial natriuretic peptide, or ANP. Think of ANP as an emergency pressure valve. Its message to the kidneys is immediate and unambiguous. The system is overloaded. Dump the excess fluid now. The kidneys respond within minutes. They suppress aldosterone, the hormone that tells them to hold on to water, and shift into high-output filtration mode. They begin processing that returned fluid rapidly, delivering it to the bladder. Within 45 to 90 minutes of lying down, your bladder is full. You get up, you release 300 to 400 milliliters. You return to bed, but the fluid from your legs has not finished mobilizing. The process continues for hours. 2 hours later, full bladder again, then again before dawn. This is why Richard, who had not consumed a significant amount of fluid after 5 p.m., was producing more than a liter of urine between midnight and 6 a.m. He was not drinking it. He was draining it from his own leg tissue, stored there across the previous 14 hours of gravity-driven accumulation. His prostate supplement had no mechanism to stop this. His fluid restriction made no difference. The fluid was already in his body, just not in his bloodstream. His bladder was working perfectly. The cardiologist found early-stage heart failure, reduced cardiac output that made it harder for the heart to keep fluid in circulation during the day, accelerating leg pooling. The sleep specialist found moderate obstructive sleep apnea. A Lancet review of sleep apnea and nocturia found that effective CPAP treatment reduced nighttime urination episodes by an average of 56% in patients with concurrent nocturia, without any urological intervention whatsoever. 2 systems, 1 problem. 4 years of the wrong treatment. Now let me tell you about the 3 foods that amplify this process every single night. The first offender is hidden sodium, not the salt shaker. That accounts for roughly 15 to 20% of most people's daily sodium intake. The remaining 80% comes from processed and packaged food: cheese, cured meats, bread, condiments, canned soups. A single ounce of hard cheddar contains roughly 180 milligrams of sodium, masked completely by the fat and flavoring compounds surrounding it. You do not taste it as salty, but it is there. When sodium enters your bloodstream in the evening, your body immediately begins retaining water to dilute it. During the first 2 to 3 hours after dinner, you are actually holding more fluid than usual. You do not run to the bathroom, but at 1 or 2 in the morning, your kidneys detect the accumulated sodium and begin actively excreting it. And sodium pulls water molecules with it as it exits. To flush out 1 gram of excess sodium, the kidneys move a significant volume of fluid through the system. You are not waking up because you drank too much. You are waking up because you ate last night's dinner. The second problem is evening carbohydrates, particularly simple sugars consumed after 7 p.m. A small bowl of cereal, a piece of fruit, a few crackers with honey. Rapidly absorbed sugars spike blood glucose, triggering an insulin surge. Insulin, beyond its glucose management role, signals the kidneys to retain sodium and water, first causing retention, then triggering a rebound excretion cycle 2 to 3 hours later, right as you have fallen asleep. And if any degree of insulin resistance is present, which affects a substantial portion of Americans over 55, usually without any diagnosis, elevated blood glucose acts as an osmotic diuretic, pulling water from your cells into the urine. The third factor is alcohol. Even 1 drink in the evening. Alcohol is one of the most potent suppressors of vasopressin, the anti-diuretic hormone that tells your kidneys to slow down at night. Under alcohol's influence, that signal is blocked. Your kidneys run at unrestricted full output filtration speed for 3 to 4 hours after that single drink. The sedative effect may prevent you from waking at the first filling, but by the second or third, bladder pressure overrides everything. And your sleep quality throughout that entire period is architecturally destroyed. You never reach the slow wave phase that your brain requires for cellular maintenance and waste clearance. Now I want to give you the protocol, not a supplement recommendation, not a medication. A physiologically grounded daily routine that addresses the actual mechanism driving your nighttime urination. In the morning, before your first cup of coffee, stand at the side of your bed. Rise onto your toes, lifting your heels 1 to 2 inches off the floor, then let them drop back down with a light, firm impact. You should feel a gentle vibration traveling up through your calves and into your lower thighs. 30 repetitions, 1 per second. 30 seconds of your morning. This activates the venous valves in your lower legs, encouraging blood to move upward against gravity before the day's accumulation begins. If standing is difficult, do this lying down. Raise both legs straight up and shake them with small, rapid movements for 30 seconds. During the day, 70% of your total daily fluid intake should be consumed before 3 p.m. A glass of water immediately upon waking, a full water bottle during the morning, tea and soup at lunch. After 3 p.m., fluids only as needed to relieve dryness. Small sips, not glasses. Remove the salt shaker from your dinner table permanently. Season food only during cooking. Eliminate processed meat, hard cheese, and packaged condiments from your evening meal. Remove any sugar-containing food or drink after 7 p.m. In the evening, and this is the centerpiece, approximately 90 minutes to 2 hours before your intended bedtime, lie down and elevate your legs above heart level. Place your feet on the armrest of the sofa, the back of a chair, or prop them against a wall. Your heels should be higher than your chest. A 30 to 45 degree angle is sufficient. Hold that position for 20 minutes. What happens during those 20 minutes? The fluid stored in your lower leg tissue begins draining back into the venous system and returning to the central circulation. Your heart detects the volume increase, releases ANP, and your kidneys shift into active filtration mode. 30 to 50 minutes after you complete this exercise, you will feel a clear, full urge to urinate. You will go. You will produce 300 to 400 milliliters, the exact volume that would otherwise have woken you at 2 a.m. Your legs have been wrung out. Your kidneys have processed the returned fluid. When you lie down for sleep, there is no reservoir left to redistribute. If you have visible leg swelling by evening, add graduated compression stockings. First-grade compression, knee-high, worn from mid-afternoon until your shower before bed. Remove them before sleep. Finally, in bed, lights out, perform 25 to 30 repetitions of correct pelvic floor contractions. Not gluteal squeezing, not abdominal bracing. Isolate the pelvic floor. Imagine slowly drawing the perineum upward, as if trying to stop mid-flow. Hold 3 seconds. Slowly release. Consistent practice over 4 to 6 weeks measurably reduces urgency episodes in adults with overactive bladder components. Richard followed this protocol for 8 days before he called my office. He had woken up once. Near morning, 5:30 a.m. Once after 4 years of 4 to 5 awakenings a night. At his 6-week follow-up, he was sleeping through until 5 a.m. on most nights. The sock marks on his legs had nearly disappeared. His cardiologist noted that his cardiac output markers had improved. His wife had moved back into their bedroom. He told me he felt 20% younger in energy than he had in years. I told him that was not a metaphor. That was his glymphatic system finally completing its maintenance cycle. That was his body doing exactly what it was designed to do, when given the correct conditions. I want to hear from you before you move on. Do the thumb test right now. Press the pad of your thumb firmly against your shin bone, the hard ridge along the front of your lower leg, about 4 to 5 inches above the ankle. Hold 10 to 12 seconds. Release. Does a pit remain in the skin? Does it stay visible for more than a few seconds? Write what you found in the comments below, and tell me how many times you wake up at night on average. And your age, because the fluid redistribution mechanism I described becomes significantly more pronounced after 65 than it is at 60, and that affects which part of the protocol deserves the most emphasis in your specific situation. I read every comment. The comments here genuinely shape what I cover in the next video. If this gave you a framework you did not have before, subscribe. What comes next? On the specific nutrients that support venous wall integrity after 60? On the blood pressure pattern that most people never have explained to them? And on the sleep architecture changes linked to glymphatic dysfunction. All of it connects to what you just heard. There is one more thing before you go, and I need you to pay attention to this. Everything we discussed today, the venous valve failure, the cardiac overload, the kidney redistribution at night, shares a single upstream driver that almost no one in their 60s has had explained to them. It is not blood pressure, it is not cholesterol. It is a specific pattern of vascular inflammation that begins quietly in the endothelium, the inner lining of your arteries, and accelerates after 60 in ways that are directly modified by what you eat for breakfast. That video is on your screen right now. It covers the 3 specific breakfast habits that most Americans over 60 consider healthy, and that research now links directly to accelerated endothelial aging and the vascular stiffness that drives everything we talked about today. Watch it next. What you find there changes the morning before the evening protocol even begins. I will see you in the next one.